first of all, just tell everybody and remind us, what is the Association of Salaried Medical Specialists?
So we're the union for senior doctors and dentists. Our members they work for a salary as doctors, okay? So they work in the public sector. Most of them are employed by Te Whatu Ora, but we have a few salaried GPs out there, and we have people working in hospices and some other community health setups around the place.
So if I'm a private sector, say clinician or surgeon, or I work 50-50, do you cover me or not? So
If you're a member in your public work, yeah, in your salaried work in the public sector, if you join us, and most do, then yes, we do cover you for the public portion of your work. Yep. If you work in private and you were salaried, we could cover you for that as well. But most people, when they work in private, effectively work as contractors or independent service providers of some sort.
So theoretically, despite being a trade union of a description, you know what you're doing. You're at the coalface of clinical service in our public hospital system and public health system in general. Your reaction
I would argue that unions in general do know what we're doing, but
I didn't say that. Sorry, I said you know what you're doing. Yeah, I said despite being a union. Yeah. No, I'm not arguing that you don't know your job, Sarah, and I respect and admire many of your predecessors, in actual fact, in their role. I've had a bit to do with them. But moving on, your reaction yesterday, please, to the sacking of the Board of Health New Zealand, and you would have heard my introductory remarks. I was amazed there was even a board to start with. I don't get that. That just seemed another layer of stupidity on already huge layers of bureaucracy. What were your thoughts on it?
I think if you're talking about the whole of New Zealand's public health system, which is what Te Whatu Ora is, they are charged with delivering health services, community-based and hospital-level care across the country. A level of governance is a reasonable thing to have in place. Whether or not that level of that governance system was functioning as it should could be debated, but replacing them with effectively a man with an axe. So you've got Lester Levy, now the Commissioner, tasked with saving over $1 billion from our health system, doesn't seem like a way to invest in our public health system. So, our take on it is structure it how you like, but staff it appropriately. And in terms of staffing levels in our hospitals and our community health centres, we don't have enough doctors, we don't have enough nurses, we don't have enough allied health workers. So that's really our beef.
Yes, the New Zealand public health system is a cock case. I was elected for 3 terms, I'm trying to remember, 2004 to 2014, onto my local district health board. It was a cock case then. It was, you were always fighting as a district health board against the Ministry of Health officials who were always wanting you to cut money anyhow. And some DHBs did and some didn't. But the quality of care over New Zealand was distinctly variable because there were so many district health boards, each with their own organisations and levels of priorities. Te Whatu Ora was meant to actually cure all that and introduce some sort of uniformity, make sure we didn't have a postcode lottery we've got, make sure we're adequately staffed across the country, that tertiary services and facilities were available to all. 2 years later, the government is saying, well, they might be moving there, but they're moving there at such a way that they're not delivering the services at the moment either, and they're losing $130 million a month. Can you understand why they intervened yesterday then, as a consequence?
I don't think we've had a decent, honest conversation nationally about what it actually costs to fund our health system to the level that Kiwis expect. If people expect that they're going to get their cataract surgeries, their hip replacements, their gynae surgeries in a timely fashion or at all, as well as getting care if they are in an accident, they're a trauma case, or they become acutely unwell and need to be admitted to hospital. So our hospitals are still pretty much keeping up with acute demand, but they are in no way managing planned care, which is your hip surgeries, your cataracts, et cetera. Yeah, that's right. And women with non-cancer gynae issues are simply not being seen anymore. Now, is that good enough? Is that a good enough standard of care to be providing across our country? We need to have better conversations about what does that look like, providing that level of care, and what does it cost? And no, I don't think Te Whatu Ora have done a great job thus far, but they are tackling decades of, effectively a kind of competitive regional system that you just described, right, with one DHB.
Oh, it was a crazy system. It was a mad system. 20 years of failure.
So I'm just worried that they're throwing the baby out with the bathwater. But the other thing is, so now we've got targets again, and we are being asked to find savings and cuts in health funding. But are we actually having a clinically informed conversation about what that's going to mean? Because, in terms of percentage of GDP, New Zealand doesn't invest that highly in our health system compared with, similar countries. We know that acute hospital demand is rising at a higher rate than population growth. And we also know that if you look at the workforce metrics, and not all of those are reliable, but many, many services have not had staffing increases or wider resource increases to cope with increasing demand or the improvements in technologies for a number of years. So on top of the staffing shortages, we've got the physical plant and infrastructure that have not been invested in appropriately or kept pace.
I get where you're coming from, except this, Sarah. We are not a rich country anymore. I mean, the difference, I'd say, between 1990 and 2024 is that we're not as rich as we were. We're billions of dollars in debt. We're struggling to cope with basic services. Health is one, yes, education's another, policing, law and order expectations, etc. Mental health, another issue. Every sector of our economy is demanding investment, and an investment that we really don't have or aren't sufficiently taxed to employ. So I take it that you would generally accept that concept, but you're saying what? That we need to have an honest discussion about rationing healthcare, about priorities, about where we're going to invest first?
So are we going to ration it and be honest about that? Are we going to look at taxation and how we fund the health system and what level that might require? So they are things that we do need to talk about. Absolutely.
And your argument is we're not having that discussion. It's a sort of a bidding war that each political party goes through every 3-year election cycle.
Unfortunately, we seem to. But the other thing that is missing is while it is expensive to run a health system, it's more expensive to try and run an economy where lots of people are chronically unwell or not having health needs met. So I think, the cost-benefit data generally suggests that for every dollar spent on healthcare, you get a decent return, right? So we are better off in terms of trying to have a productive economy, having enough people who are well and able to participate in contributing to that economy. If people are laid up and unable to work with preventable health conditions or curable health conditions that aren't being prevented or cured because our health system isn't funded for that, then there will be costs that aren't counted there, but they will, as you described, flow through an economy that can ill afford that kind of a scenario.